Preview.
Coming to Grips with Symptoms by Marty McCafferty, EMT, DMT. The diver was an experienced 43-year-old female with more than 150 lifetime dives. She was reportedly healthy and reasonably fit. She had not taken any medication regularly. The dives were made in the ocean from a private vessel. The diver breathed air and performed 3-minute safety stops on each dive. The diver temperature was in the order of 15 degrees centigrade. So the diver wore a dry suit with attached gloves. The first dive was to 24 meters for 22 minutes. After a 1-hour surface interval, she made a second dive to 17 meters for 40 minutes. Despite her use of dry gloves, the diver's hands became cold, especially during the second dive. At the surface, she reported reduced sensation in both hands with associated loss of grip strength. She and her divers attributed the symptoms to being cold, and they headed home. The diver experienced some difficulty driving due to reduced sensation and strength in her hands. Thinking her symptoms resulted from being cold, she spent more than an hour immersing her hands in warm water, but noted no further change in symptoms. Concerned that these might be the result of decompression sickness, she called Dan. The diver and Dan medic discussed her dive profiles, breathing gas, and any potential issues she may have had during the dives. The discussion turned towards the symptoms themselves, their time of onset, character, and evolution. During the conversation, 2 important pieces of information surfaced. Firstly, her wrist seals were well used, meaning the chances were very low that constriction itself had impaired normal circulation. Secondly, the diver had a history of similar symptoms. The diver reported a history of carpal tunnel syndrome previously, and upon reflection, she noted that her present symptoms were essentially identical to those she'd had before. Once carpal tunnel symptoms became a possible explanation, the medic sought to determine whether there was some activity during the dive that had aggravated the condition. The diver explained that the dives were done to familiarize herself with the use of a new camera housing in the marine environment. She confirmed that she had an appropriate amount of ballast, but also realized that her trim position wasn't ideal. The housing tended to float with the lens side up, which required her to flex her wrists to bring the camera in the usable position. The Dan medic encouraged her to be evaluated at a local hospital emergency department that day. There are no tests or imaging methods such as X-ray, CT or MRI to diagnose decompression sickness, and the diagnosis is typically reached by process of elimination. This can be more difficult when there are pre-existing conditions that mimic the symptoms of decompression sickness. In this particular case, 3 primary factors were associated with the diagnosis: the dive profiles, the proximity of symptom onset to diving, and symptoms being consistent with decompression sickness. In relation to each of these, let's consider them. The diver's profiles were 24 meters for 22 minutes on air, and then 60 minutes surface interval, followed by 17 meters for 40 minutes on air. These are not particularly aggressive profiles, but DCS cannot be ruled out on the basis of the exposure alone. The actual onset of symptoms is somewhat unclear due to the fact that the diver's hands were cold. However, it was well within 24 hours, which is the time frame within which decompression sickness symptoms are expected to occur. 80% of decompression sickness presents within the first 12 hours after a dive. Regarding the specific location of symptoms, there are no documented cases of decompression sickness in which symptoms occurred in both hands and nowhere else. And one might argue that a pre-existing musculoskeletal condition might predispose this diver to decompression sickness. But there is very little evidence of this possibility. predisposition to decompression illness is not supported by data. Dan's recommendation was that the diver seek medical evaluation to ensure review of other possible signs and symptoms. The conclusion: the diver chose to wait until the next morning so a physician familiar with her condition could evaluate her. Her symptoms had further improved overnight and remained localized in her hands. The diver did not report any new symptom development, and the physical evaluation confirmed reduced sensation in the heels of the hands extended to the index, middle, and ring fingers of both hands, with the fifth or little finger unaffected. Based on this verified presentation and the manner in which the diver had repeatedly flexed her wrists during the dives, the doctor suggested that the symptoms were consistent with an aggravation of the pre-existing carpal tunnel syndrome. The doctor spoke to one of the Dan consulting dive physicians, and after reviewing the profiles, the decision was made not to provide hyperbaric treatment and to attribute the symptom development to a mechanical cause. A diagnosis cannot be made over the phone based solely on signs and symptoms that appear in a particular list. None of the signs or symptoms listed for decompression sickness is exclusive or unique to decompression sickness, and so all factors needed to be considered. While one of the essential goals in the management of decompression sickness is prompt initiation of treatment in a hyperbaric chamber, this should not supersede a thorough medical evaluation. Medical examinations that occur prior to treatment have not been associated with negative clinical outcomes, and they may uncover other important causes of symptoms that were erroneously associated with diving. If a diver develops symptoms following a dive, encourage prompt evaluation by a medical professional, and do not hesitate to contact the Dan Emergency Hotline on 0800 020 111.